Hello, everyone. There's a new paper in intensive care medicine which I find very interesting about COVID-19. So I'm just gonna wrap up what they say, and you can read the full paper as I linked here by the Mon- Monteiro and team. Thank you very much for this paper. So basically, the group tried to identify the correlation between histopathological feature of COVID-19, which is the damaged lung, and and lung ultrasound. So the goal is to actually see that, we can see if with lung ultrasound if the extent of the damage of lung. So basically, there are three steps in this paper of lung damage. So the first one is normal lung. The second one is in acute phase, is called exudative diffuse alveolar damage. The third one, which is the hallmark of COVID-19 lung damage, is fibroproliferative alveolar damage, which in this paper, they say that the last stage is actually the one that we can identify with lung ultrasound score. So let's wrap up a little bit about lung ultrasound. So at the in your left side is A line. I'm sorry, I didn't. My face is on there, but I want to move it. So if you have a normal black lung or no fluid at all, it will be A line, the horizontal white line. If there is any fluid, blood, or alveolar damage, you have B line, so this side. So basically, you have vertical white line. But if you have severe lung damage, COVID-19 example, what you would have is actually you have a lot of B line, because B line caused from reverberation, or the sound is bouncing between air and fluid, and you have confluent B line, or you could call white lung. This could be discovered with any kind of probe. So abdominal probe, echo probe, or vascular probe is fine. If you see this kind of lung feature, you have white lung. It means that in chest X-ray you would have a white lung. In CAT scan you have white lung. So basically, you have a severe damaged lung. But in another step in this paper, the group say that in people with fibroproliferative diffuse alveolar damage, or DAD, there are a lot of patterns that can be discovered as well. So the first one on your left side is actually you have irregular pleural line, the thicker, not so good pleural line, as you can see in my yellow arrow. The second one in the middle is you have irregular pleural line, and then you have a consolidation or airborne program. The third one on your extreme right side, you have consolidation all the way. So these three patterns can be discovered because you have so much fluid or so much damage that you don't have air anymore. You don't see A line anymore. So the more you discover this pattern along your lung, it's mean that you have a lot of lung ultrasound score to summary up. So this is the histopathological, which on your left side is a normal lung. On the middle is the alveolar damage. But the third one on your extreme right side is fibroproliferative DAD. And this is a hallmark of damaged COVID lung. So in this paper, they discovered that, the pattern that I said before, in people who have severe damaged lung from COVID-19, obviously in the first one on the upper left, so you could see here there's B line with asterisk here. In the upper right, you can see white lung here, and then here in this paper, this is irregular pleural line, and then this is white lung, and this one is actually normal pleural line, and then you can see here this is consolidation. You can see more in the paper in the details, but obviously this is the pattern that you do want to see in patient with COVID-19, because it's mean that the patient has gone from just alveolar damage, but they have fibroproliferative patterns. I have a tongue twister there. So there you go again. And the last one, so I'm just gonna wrap up. It's pretty easy. So as you can see here, when you have so much lung ultrasound score, you know the pattern that I said before, white lungs, consolidation, you know, air bronchogram. This patient would have histopathological fibroproliferative diffuse alveolar damage. In this paper, they conclude and discuss that maybe lung ultrasound could be another option that you could see the marker if there is any extent of fibroalveolar damage. Of course, you would have, you know, if you have CAT scan, it would be better, but you cannot send CAT scan every time the patient gets dyspnea, or you want to progress every day, you know, how your management or how you manage your ARDS goes. So this could be a good way if there is less of this severe pattern, you know, whether less consolidation, less white lung, you know, you would like to see more of the A line or just a few B lines would be better for your patient. So you could read this paper in full paper on intensive care medicine. I'm going to put the links below, and thank you very much, and sorry for my tongue twister again, and hope to see you again. Thank you.